as treatment has improved over the years, many of the young children that were diagnosed with ALL, of course, now are treated much more effectively, and so the long-term survival of these individuals is much better than before, which is a very positive point. But then we also need to have much more attention to the long-term side effects of the treatment on these young children. And so some of the long-term side effects that we all know very well are effects on fertility, potentially in these young children, cognitive changes as they are still learning a lot at their young age, and then have a cognitive dysfunction might impact their learning and memory capacities. Cardiac problems are quite often observed after treatment, and also then effects on bone disorders, osteoporosis, osteonecrosis are common to already name a few. There's more effects, but these are some of the ones that I believe are probably the most important ones. And now with the new treatments such as CAR T-cell therapy or other immune therapies, some other long-term side effects might appear that we are currently not aware of, because these treatments are just too recent to know. And so it's definitely for those patients good to be aware of these long-term effects that they could expect, and also to anticipate on that, and also to talk about it probably with other patients to learn how they cope with this, and what they can do to minimize these effects. So maybe I just want to ask Charles first to see if you know, Charles, from your experience at St. Jude, if there's any of the side effects that are more important than others, or if there's any changes in the coping with these side effects over the last years.
It's a very important question. It's a complex one, though, in terms of what are more important. I mean, I think, just touching on a couple of issues that I think are areas of active research that kind of both influence the type of therapy as well as managing long-term side effects. So steroid-related effects, because there's a lot of interest in reducing intensity of therapy now. This also ties into the molecular subtyping, where, can we use that or other information to identify children that are curable with less intensive therapy that may be spared some of these side effects, and steroids are one in particular. Another one is asparaginase, which has, I guess, more short-term side effects, but is also a topical issue because increasingly regimens are thinking about replacing the use of asparaginase because it has multiple difficulties as well as toxicities with novel approaches, particularly early in therapy, such as earlier use of immunotherapeutic approaches. And I think, another important point is recognition of toxicity. And, I think often perhaps people are more aware of the acute toxicities, the osteonecrosis, the pancreatitis, those sorts of issues, and tend not to think so much about the long-term issues of fertility, of growth, of intellectual impairment, and also the long-term burden of second malignancy. Perhaps not as high in ALL second malignancy as some of the other tumours that are recognised in children, but it is very important. And I think the very large studies from the Maximo, from the US, from St. Jude, etc., have shown that the burden of long-term toxicity is much higher than people often appreciate. So these are all, I think, super important issues. That's not comprehensive, I don't think, but perhaps some of the important issues.
Okay, thank you very much. Yes, are there other responses to this, especially then recognition of these long-term effects? Is that something that you, from your own experience, are aware of, that this is a major concern, a major problem?
I think it is. I mean, probably not from the patient perspective and patient advocate perspective, but I think from the general community it is, and perhaps even clinicians may not be quite so aware of the burden of long-term toxicity. And it is important, and, again, is a major driver of trying to reduce therapy intensity now that we have these newer approaches.
Yes, indeed. Thank you, Charles. Any other responses to that? Is someone want to continue on one of these aspects?
Yeah, I think there is, sorry, Anne-Pierre again, and sorry for the background noise if there is, but there's something, so I was at the European Blood Marrow Transplant Conference today, and it was just really interesting to listen to some conversation around graft-versus-host disease. I know not all ALL patients will get a a bone marrow transplant, but the ALL 3+ will. So I think it's very important to actually raise awareness in patients that they should be vigilant to potential manifestations of graft-versus-host disease, because when it's treated early on, the outcomes are much better. But actually, if you wait too long and you kind of discard them, then you can develop fibrosis, which is not reversible. So I think also patients that survive, once you get minor sort of, if it's moderate GVHD, moderate is already a problem. But if you've got minor to moderate GVHD, sometimes you don't always actually identify it as being GVHD. So I know it's only a subset of the community, but I think just raising awareness in patients that as soon as something unusual comes up, that they should really have that conversation with their medical team. And not assume it's nothing and it will go away.
Yeah, thank you for sharing that. Yeah, graft versus host disease, indeed, also another side effect if there is bone marrow transplantation involved. I think Sharon, you also wanted to say something, and then Pete afterwards.
Yes, last week we had Dr. Neklu Dove. I hope I'm saying her name correct. She's an internist from Harvard Medical School, and survivorship is one of her specialties. And secondary cancer is an issue. Long-term heart issues from the adriamycin can be also an issue with survivors. It's important that we educate the survivors to be aware of this, and also their primary care physicians, because by the time they start having side effects, they're outside the oncology clinic. There's some good information through POG and through Live Strong, has some good survivorship sheets that can be used.
Yeah, that's definitely very important also to have enough information about that, so that patients themselves and the families can find information so that they're aware of this. And do you think there is sufficient information out to inform them, or should that be a point of attention?
Well, this survivorship has been a big issue here in the U.S. for the last 10 years, and there's all sorts of survivorship checkoff list on when they should be getting their mammograms earlier if they're a childhood survivor. Colonoscopy now has been found to be very important because a large number of polyps are being found in much younger childhood survivors. So that's what's important, is to know what screening they need to have and when they should have it. Having chest scans every so often if they had any radiation, and heart baselines if they had the adriamycin, so they could have something to watch and to be aware of.
Okay, thank you very much, Sharon. Then Pete, I see your hand is up.
Yeah, I just kind of want to reiterate what other people have said about how I think this is incredibly important and crucial to patient experience, especially when it changes from the caregiver, the hospital setting, having a very proactive role in that, to the patient themselves, needing to have that awareness and that kind of thing. And just speaking from my own experience, I was told, the official advice I was given was that complications with bone from steroid use was very, very rare. But I knew from kind of anecdotal evidence from other people who I'd met that it actually was a lot more common than they were making it seem. And it was only because of that I kind of had that foresight that I was, as soon as I started having problems, I was like, right, this is something that I need to see my doctor about as soon as possible. And kind of the more patients who know about what to look out for and when to kind of seek further advice, I think the better in terms of long-term quality of life and that kind of thing.
Yeah, thank you. Yeah, it's of course very individual for each patient. It's much different how they experience this period after treatment, directly after treatment, or longer term after treatment. And so it's everyone can learn from each other on what to look for and how to deal with that. I think there's also much more attention now to these issues from the societies such as the American Society of Hematology and the European Hematology Association, who not only focus on improving treatment, but especially also on that aspect on surviving healthy with after leukemia treatment or after lymphoma treatment. So in that aspect, this is also very important that these bigger societies also watch on that and also give grants to study these aspects. Is there any other reaction at this moment on Charles?
Just that survivorship is not really my area, but there are some people that it's their entire career here at St. Jude that would be very glad to give input. Greg Armstrong, Melissa Hudson, for example. Greg also runs the CCS, the Childhood Cancer Survivorship Study. So, if you do want more enriched information about this area, there are others we could loop in.
Mm-hmm. Yes, very good point. Yes.